Hello, and welcome to this series of video lectures produced by the Safe States Alliance and the Society for the Advancement of Violence and Injury Research. This lecture is on planning public health interventions. It's part of the series where we are developing, through our collaboration and with the funding from CDC, a series of lectures that bring together leading scholars in the field who will provide information and examples that can be used in various settings. We're doing this because we hope to raise awareness about the field of injury and violence prevention among students, professors, and practice professionals, and to familiarize all public health students with a basic understanding of injury and violence prevention, even if that isn't your primary area of interest. So I'm Carol Runyan, Professor Emerita from the UNC Gilling School of Global Public Health and a former director of the UNC Injury Prevention Research Center. I'll be talking about the Haddon Matrix and the third dimension. The learning objectives for this session are to describe the elements of the Haddon Matrix as an intervention planning tool, explain the process of using value criteria, what I refer to as the third dimension, in the decision-making process, and to show you how to apply the planning models with some examples of specific topics. This fits with the SAVIR criteria of designing population-based policy program projects or interventions and applying awareness of cultural values and practices to the design, implementation, or critique of public health policies and programs. So let's begin applying public health principles to developing preventive interventions. This diagram may be familiar to you already, as it's a standard kind of planning diagram in public health, where starting up in the upper right-hand corner there in the black arrow, we base what we're doing on our foundational principles of public health and on defining the epidemiology of the problem we wish to address, drawing on surveillance data as the usual way of determining what those problems are. From there, we develop our planning process by developing an understanding, a deeper understanding of the problem and the population affected. We define the nature and the magnitude of the problem, the scope of the problem across the population, and we identify and engage stakeholders who can help make sense of what's happening in that environment. They can help examine characteristics of the population and help us use data through their engagement to understand where we're working and what we need to do. From there, we identify potential targets of change and consider evidence-based strategies that may already exist, or if they don't exist, we think about what should be the evidence based on good theory. From there, we develop a logic model that examines how we think our intervention that we're thinking of should work in the change process, choose our strategies, set goals and SMART objectives, and then develop our implementation plan. And as you will notice, there's some arrows that circle back to the earlier boxes. And this is because often we need to revisit, as we go through the process, we often need to revisit some of the earlier steps to make sure that it all makes sense together. But once we've gone through this process and circled through, then we're ready to move ahead. And moving over to the left side of the diagram, we'll develop our evaluation questions and strategy for measuring change. We'll want to do process evaluation to measure how the implementation actually worked. Were there glitches in the implementation that might have affected how things turned out in terms of the shorter term impact and outcome evaluation that we'll also design? And once we figure that out, we'll choose our evaluation design, whether it's an experiment with a randomized trial, perhaps a quasi-experimental evaluation design, or a more straightforward pre and post design using the same study population. From there, we'll want to pilot test both the implementation of the evaluation and also the implementation of our evaluation. And that's referred to as formative evaluation, sort of like being in a test kitchen and testing out, did your recipe really work before baking the cake, say, for the wedding? You might try it out first and then make revisions to how you plan to do the intervention and how you plan to do the evaluation. It might be, for example, that some of your evaluation questions, when you test them on a small group, don't really make sense to them and you need to change the wording. Or maybe the font is too small for some groups, things like that, to just make sure that you're going to get the best results you can by doing it the way you actually intend. But once you've worked those kinks out, then you're ready to go on and implement as planned and collect evaluation data. And then once the intervention is complete and you've collected your evaluation data, you will, of course, assemble it, interpret it, and then disseminate it to others so they can use that in planning their next interventions, and the cycle continues. In this lecture, though, I'm only going to be talking about these two elements of the planning process, but wanted you to see the larger context. So I'll be applying public health principles to injury prevention in the next a set of slides, but I want you to think about, even if you're not an injury and violence prevention person, I want you to think about how these principles could apply in other areas of public health as well. So first of all, reminding you of what I think you probably already know, the classic agent-host environment model of public health. And here's an example applied to salmonella food poisoning, where down here at the bottom, we have the person, the host, who's the person who gets the food poisoning. We hope it's never one of us, of course. And then the agent in this case is the bacteria, the salmonella bacteria that causes the food poisoning. And it's transferred to the host either by vehicles, inanimate objects like dirty utensils perhaps, or by a vector, which is an animate, a human or animal. In this case, an example might be the person who handles the food, who may be sick themselves and didn't wash their hands properly. And this all happens within the context of both the physical and social environments. Things like the enforcement of restaurant inspection, norms around food handling, the design of the kitchen, does it have sinks and hot water, refrigeration capacity, and the enforcement of laws about restaurant safety, for example. So that's an example in the infectious disease realm that is more familiar to many of us. Well, let's apply it now to the injury realm. It's the same idea. In this case, I'm using a motor vehicle crash as the disease, if you will, where the host is the occupant of the car who is affected. The vector might be other drivers. The vehicle is the vehicle itself, the car. That's one way to remember the difference between vehicles and vectors, is that the vehicle, in the case of a car crash, the vehicle is the vehicle. And in the case of injury, we usually talk about agents as being energy. And in the case of a car crash, that energy is usually mechanical energy from the collision itself. But it might be thermal energy if there's a fire. There might be chemical energy in the case of a poisoning, radiation energy in the case of sunburn, say. And so you have to think about what the other types of energy might be and the other types of agents, depending on the injury problem specifically. But that model applies very well. And again, in public health, we often think about the social ecologic framework, which is similar to the different layers of the social and physical environment that I just showed you in the classic public health model. But here I have it shown as the individual, relationship, organizational, community, and sociocultural levels that are spelled out in Bronfenbrenner's social ecologic model. And when you cross that with the principles of public health of primary, secondary, and tertiary prevention, we think about healthcare is typically down here in this corner. It typically involves individuals, and usually it's in the realm of tertiary prevention. You go to doctors when you're sick for treatment or for crisis intervention. It might also include early intervention, secondary prevention, where you identify problems early and stop them before they get more severe, like in screening, for example. Mammography for breast cancer is a form of secondary prevention. And then in public health, we really focus most of our attention on primary prevention, keeping problems from happening in the first place. And so what we refer to as our upstream population focus moves us usually in this direction toward more primary prevention and, to the extent possible, into those outer layers of the social ecologic framework. But as this arrow demonstrates, or is intended to demonstrate, it's a continuum. And so there are multiple different ways to think about these different levels. As we think about the factors that affect injury and violence, we think about human characteristics, physical factors, as well as behavioral factors. And I'm going to give you examples in just a moment. We think about the products or vehicles, if you will, whether it's weapons, drugs, toys, and so on, cars. The physical environments that have an effect on the whole injury process, factors of the geography, what's around you in the environment, as well as physical structures, and the social environments, norms, and policies. So let me give you some examples of those things. So in terms of human characteristics, we think about human development. Normal development, as we go through the aging process, includes things like curiosity, like this child looking under the sink. It's very normal behavior to be looking under the sink and wondering what's in those bottles. They may be poison. Size, strength, balance. I mean, here's an older person who may have different strength and balance issues than someone of this age, as well as vision and hearing issues. And then, of course, there are behaviors that change in different populations and different age groups within normal development. Adolescents are known for risk-taking, and different people are more likely to conform to norms, to peer pressure, or to cope with stress in different ways, like with a crying baby that just won't stop. So these are examples of some of the human characteristics that we need to think about in the context of particular injury problems. They won't all apply in every situation. Then there are many characteristics of the products or the vehicles in the agent-host environment vehicle vector model. The size might be a factor. For example, in choking hazards, that might be a hazard for young children. The quality of construction, does it break easily? Maybe it doesn't work properly. Maybe there are safety flaws that it's just not constructed well. Maybe it's hard to use properly. Or maybe there are dangers that aren't clear, that it looks like something else. And here are two examples over here of cleaning products that actually might look to some people like beverages. Or here is pot tarts made with marijuana that look very similar to Pop Tarts. And so it could be confusing and cause some problems if people aren't aware of what they're actually eating. We redesign products for safety all the time. So for an example, before 1970, medicine containers were much easier to open for children. And then in 1970, the Product Packaging Act was passed, requiring these kinds of safety caps on medicine bottles. So that's an example of changing the design of the product for safety purposes. And we've done this over the years. Here's 1950s technology um, for, for child passenger protection in a car. Although I might add that when I was growing up in the 1950s, my passenger protection was my mother's right arm reaching out to keep me in my seat if she was stopping quickly. We didn't have seat belts. Whereas current technology are rear-facing child car seats placed in the back seat. So we've made improvements in both the technology and the way we use that technology over the years. In terms of characteristics of the physical environment, I'm just showing a few examples here of how the design of spaces makes a difference. Is it quiet? Does it have slip-resistant surfaces? Is there enough space to move around? What about visibility? Clear signage. This clearly is an example of poor signage, but here's an example of slip-resistant patches on a stairway to make it harder to slip down. The construction of how a home or playground or highway is constructed are also important, whether it's protected from potential hazards like smoke and carbon monoxide. We put in detectors to make that more evident. I mentioned slip-resistant surfaces, guardrails, lighting. Is it durable, or are things going to break easily and cause possible hazards? As well as maintenance, like ice removal in this picture to the right. The picture of the sliding board here is one that actually used to be in Chapel Hill, and it was a sliding board that looked like a lot of fun, but look how steep these steps are. One could fall through between the rungs, and it also happened to be over a very hard surface. We could do better and develop equally fun sliding boards that don't have those hazards. Here's an example of changing the physical environment in terms of crib safety. Rather than having lots of stuffed animals in a crib that could cause suffocation, it's recommended that babies be put in the crib on their backs and without so many potential hazards. Or thinking about the safe storage of firearms. Children, as I said, are curious, and having a firearm out on a counter might be very tempting to a young child, as opposed to making sure that they're locked in a safe that aren't accessible to children. And then comes characteristics of the social environment. Things that are governed by social policies, things like policies about access to alcohol, to opiates, policies about safe gun storage, the availability of childcare, the minimum wage, family medical leave. Those are ones that have actually been shown to be effective in reducing child maltreatment. Do we have a culture of safety and civility? For example, in the workplace, is there a culture of being safe or of taking risks? And then the social norms within a given cultural group around firearms, disciplinary practices, supervision of children. Do you leave children alone at a certain age? When is it safe? I think most people would agree it's not safe at, say, age 2, but some people might think it is okay at 8 or at 12 or at 14. What are the norms around drinking? What are and how do caregivers respond to persistent crying and avoid shaking an infant who's just won't stop crying? And cultural norms about some of these behaviors are illustrated here. I've mentioned some of them already. I think I've mentioned most of them already, actually, and just with some other illustrations to help you think about those. And I'm sure you can think of many more. Norms about child discipline are another example. Do we use a belt to thrash a misbehaving child, or do we take them aside and talk to them instead? Do we shake a crying baby? No. that can cause serious brain damage and death, versus just putting them aside in a safe place and walking away and letting them cry it out. We have multiple intervention approaches we can use, and I like this list because it rhymes. We can educate, regulate, legislate, or usually as a last resort, litigate. And I'm going to give you some examples of those in a moment. Education can be directed at a lot of different targets. It might be education of children directly. For example, stop, drop, and roll if you're in a fire situation. It might be education directed at caregivers and teachers. For example, how to calm a crying baby, or how to handle a classroom fight. It might be for other types of professionals in health and social services or in law enforcement. Or we might do education to decision makers, either organizational leaders about the benefits of paid family leave, or of policymakers trying to institute state or federal laws, or laws at the local level. So education isn't just directed at the potential victims of injury, but at a whole range of those who have influence over the process. Regulations can be made for products, for example, how we package medication, what toys are allowable on the market, and what toys may be allowable for certain ages, who can gain access to marijuana, and how is it packaged. We also regulate professional practices and training, prescribing practices around opioids, for example, or when we screen for domestic violence or child maltreatment or other kinds of issues, and what sort of reporting we do if we discover when screening, if we discover that there are guns in the homes, or that someone is suicidal, or that there's abuse going on. We also regulate community practices. Think about, during the COVID epidemic, our policies around vaccination and masking and distancing. And there might, just as well as in the injury field, community practices around safe driving, whether teens can drive themselves to school and with how many passengers in the car, and who can go to the playground at certain times. So other kinds of issues. There's legislation, and so we can legislate to require or limit certain kinds of behaviors. We require usage of car seats, for example, in all 50 states. In many states, there are requirements about safe gun storage, corporal punishment, the wearing of masks during the pandemic, for example, immunizations of different types. We can also legislate the design and availability of products, marijuana and how it may be packaged, the availability and use of car seats, bike helmets, and so forth. And also, obviously, we legislate appropriations to support health and welfare agencies that have an effect on whether injury and violence is going to happen, including preschool programs and many other types of appropriations for health research and for health department initiatives. And then we also legislate that there be certain types of training for providers of different services. What type of training do you need to be a physician, to be a nurse, to provide mental health services, and so on? And then, as I said, litigation is often the last resort, but has been used very effectively in areas like product design, when there were unsafe toys, guns, cars, that litigation, or even the threat of litigation, can be sometimes a powerful motivator. Also, there is litigation that applies to practices, medical malpractice, or failure by workplaces to comply with OSHA standards may result in litigation. So those are all tools at our disposal. And they're not mutually exclusive. They're often used either sequentially or together. Now, we know, for example, that changing people is very hard. Many factors keep people from doing what they know is preferable practice, that what they know is healthy, what they know is safe. But people forget to put their seatbelts on. They may not like to wear a bicycle helmet or floss their teeth or whatever. So we in public health try to make sure that the safe or the healthy choice is the easy one so that we don't have to rely on people to make individual decisions every time they're confronted with a potential risk. As a result, we also recognize that education, although it's important, is rarely by itself sufficient and the best approach. But as I've already mentioned, it's often a critical component of an overall strategy and may be applied, as I've just shown you, to multiple different target audiences. And so often in injury control, we try to figure out ways that we can change environments, change systems, modify products, as usually the better way to reach our goal in public health of moving upstream to primary prevention, to providing universal protection for everyone, and to reducing disparities. As a general principle, Susan Baker, one of the early leaders in injury prevention, developed this diagram to show that as a basic principle, the less effort that's required, the greater the likelihood of success. And this goes along with what I was just saying, is that it's often hard to rely on people to remember or know what the right thing is to do in every situation. So as an example, asking parents or caregivers to check the water temperature before giving a baby a bath every single time requires some effort, and as a result is less successful than if we change the environment over here in green and make sure that there's a safe setting on the hot water heater so that it only comes out at a safe temperature, so that when that caregiver is distracted or forgets or doesn't know in the first place what a safe temperature is, the baby doesn't get burned. So this is a very simple example of how there's more success when the less individual effort is required. We can't always do that, but it's something to aspire to when possible. So moving on to the Haddon matrix. William Haddon was a leader in injury control in the 1950s through early 80s. And he applied basic public health concepts to his matrix as a way to facilitate understanding injury events and planning interventions. He drew on the agent-host environment model, as you'll see in a moment, and then on the concepts of primary, secondary, and tertiary prevention, although modifying that idea of temporality a little bit in defining pre-event, event, and post-event strategies, which I'll explain in just a moment. So this is what his matrix looks like, and I'll give you the reference for this 1980 paper at the end of the talk. The matrix consists of columns that are factors that can potentially be changed. The host, or the person who's vulnerable, the agent, which might be a vehicle, like a product, or a vector, like in the case of violence, it might be another human being who causes the transfer of energy to create the damage. And then the physical and social environments. The rows refer to the point at which interventions have their effect. Is it at the time of the event? They're in the middle to prevent injuries from occurring when a potentially injury-producing event occurs, or are they interventions pre-event that keep this event from happening in the first place? Or are they interventions at the post-event phase that minimize the damage that may occur once the event happens. So let me go through an example with you to make this a little clearer. But as you use the model, the first thing you do is you define each column and row based on the problem that you're addressing so that it's clear what exactly you're talking about. So here, with the factors that can be changed, I'm defining the host as the person in a car crash, the car as the vehicle, and then the physical and social environment. That's a little easier. And in this case, I'm defining the event as the crash itself, the moment at which the vehicle crashes into another object, or I suppose it could be a pedestrian or a bicyclist. That's what I'm defining as the crash. So anchoring on that allows us to define what is pre-crash, before the crash, pre-event, before the crash, or post-event, after the crash, and then be able to fill in these cells of this matrix. So let's look first at the before crash row. We can do things to change the different factors. We can try to teach drivers traffic laws. We can discourage driving after drinking, texting while driving, and so on. Usually those are educational approaches. Along with that, we can try to make changes to the car, make sure that it has updated safety features installed and that everything is working properly. Good tires, good brakes, the mirrors are in place, and so on. We could also look at the physical environment. Are the roads well maintained, and make sure that they are well maintained, that they're plowed in the winter and that they're not icy, that there aren't big potholes, that there isn't debris on the road, that there are clear signs and markings on the roadway so people aren't confused about where to turn off or how to enter a roundabout, that there's good lighting so they can see pedestrians and bicyclists and other cars. We can also look at factors and modify factors in the social environment, thinking about the norms about using designated drivers and trying to stress the importance of not driving while under the influence, stress the importance of obeying speed limits, and ensure that we're enforcing those laws and texting laws, and instilling graduated driver licensing as a policy to ease adolescents into the driving task. So those are all examples of pre-event strategies. Strategies at the event phase sometimes get a little confusing, so I want to be sure I'm clear about this. This is where we encourage seatbelt use. And I know many of you are thinking, wait a minute, don't you put your seatbelt on before there's a crash? Aren't seatbelts put into the car well before, you even buy the car? Yes, but they have their effect at the time a crash occurs. Seatbelts don't, generally speaking, prevent you from having a crash, but they prevent you from getting injured at the time of that event, which in this case is the crash. Similarly, passive restraint devices like airbags in the car are, yes, installed at the factory, but they have their effect when a crash occurs and they blow up. Similarly, energy absorbing light and sign poles that collapse if a car hits them to prevent less force being transmitted to the car, to the passengers. Open space at the edge of the road so that if you do exit the highway out of control, you don't immediately hit a tree, but they're a little farther off and there's a chance for you to slow down. And in the social environment, in the event row, supporting advocacy for enforcement of the laws that relate to seatbelt usage, speed limits, texting, graduated licensing, and so on. And then in the post-event phase, teaching first aid skills to everyone so that in that first column for the person who is actually hurt in the car, whether they're the driver or other passengers, that they can help themselves and each other before other help arrives. Making sure that the vehicle is as safe as possible, that it doesn't burst into flames at the time of a crash, and installing GPS and crash tracking devices in the car so that if there is a crash, there's a notification for help to arrive. Having emergency call boxes along the highways that are easy to reach and easy access for ambulances or things in the physical environment that might be implemented. And then making sure that quality emergency care is accessible. We often talk about the importance of the golden hour, that mortality is reduced if victims of injury can reach a trauma center within an hour versus taking longer. So the Matrix is a really excellent brainstorming tool for, I think, best used in a group where you can put it up and people just shout out and say, this goes in physical environment event, this goes in social environment pre-event, and just filling out a matrix with all the wild and crazy ideas you could think of, and then starting to sort them. But there is the rub, because the matrix doesn't guide you on making the choices among multiple options. It's a great way to generate a lot of ideas and have them organized. So that's where the third dimension comes in. And I developed this third dimension growing out of training I had in policy analysis. And what you see is here on the front phase of this three-dimensional matrix, cube, whatever, some people have called this Carroll's cube, is you have the pre-event, event, and post-event phases, as you saw in the matrix, and then the factors that you saw in the matrix. And then this third dimension relates to criteria for making decisions about what to choose from among all those ideas that you might generate. So I'm going to show you what those things mean and how you can apply them. So the point here is to consider within the environment in which you're working, what are the values that you want to apply in making your decisions about what kinds of interventions to do. The values that might apply in New York City might not be the same as on the Navajo reservation in Arizona or in a small town in rural Mississippi. So you need to think about the environment in which you're working and what values really will adhere. And that's where your discussions with local stakeholders are really important, because they can help you sort that out. So the first step in using the third dimension is to clarify what your values are that you're going to apply in your decision making. And here are the ones I typically suggest using, but there, as you see at the bottom, there may be others. So I'm going to talk one by one about effectiveness, about equity and fairness, stigmatization, cost, freedom, acceptability to the community, and feasibility. And I make a point, feasibility is always the last one to consider, and I'll explain why when I get to it. So let's go through each one. But before I do that, I want to also point out that in using these different ones, you should be thinking about what evidence you can apply to support how effective something is, what the cost is, what the preferences actually are, and what the judgments are of stakeholders or theory if no evidence exists. But there are a number of ways to just not make this up in your head, but rather to use actual data from the literature that's already published, or from doing some surveys and analysis of your own. So keep that in the back of your mind as we go through each of these and think about what kind of data you might use to understand whether the values that you've put forth are exemplified by the interventions you're considering. Okay. So first of all, I think the first one to look at is effectiveness. Is there good evidence that this intervention that you're considering works? There won't always be evidence, and so you may have to resort to should it work based on good theory, professional judgment, and or the experience of others who have tried it, but maybe not done careful evaluation. Obviously, it would be best if you had good quality evaluation data to prove that something works. That isn't always possible. But I would argue that if you have good reason to believe something does not work, I would take it off your list pretty quickly. There's no point in going through the other steps of other kinds of values if you know something doesn't work or it's very unlikely that it will work. So look at this one first. And then think about cost. But that often people think about, well, how much does it cost to do this? We have to hire these people, we have to, buy this device, whatever. But I encourage you to think about both the cost of doing the intervention as well as the cost of not doing it. What are the human costs? What are the healthcare costs? What are the work loss costs if you don't do it in terms of the injury burden that was created by not paying for the intervention? And also thinking through, who is it a cost for? Do the people who are at risk pay for the cost? Is it general society? Is it the manufacturer of products? Your decisions about the intervention may vary depending on who bears that cost of doing it and who bears the cost of not doing it. So it's not as simple as it might look at first glance. With many public health issues, freedom comes into play. And you have to think about whose freedom might be infringed by the intervention, whose freedom is protected, how much and what type of freedom, which freedoms are affected. I mean, we're a freedom-loving country. We were built on the foundation of freedom from royal rule when we started the revolution 250 years ago. But it's not as simple as it sometimes looks, because sometimes restricting one person's freedom allows freedom for others. So, for example, there's a lot of debate about firearms, as you, I'm sure, know, the freedom to carry a gun into certain types of facilities. Well, one might ask, yes, if you make it so people can't carry a gun into the classroom in which you may be sitting right now, that individual's freedom is restricted, but your freedom to be in that classroom without a gun present may be protected. And there are a number of examples like that. That's one of the more dramatic ones. But there's also the question of how much freedom and which freedoms are they? And I used to challenge my students to think about, and I'll challenge you to think about, the last time you were in a car in the United States, you probably weren't even aware that you did not have the freedom to be driving a car without shatterproof glass, because shatterproof glass is a requirement of vehicles in the US. But I'd be willing to bet that that's not a freedom that you really worried about and that bothered you, that you couldn't buy cars with glass that shatters. So not all restrictions of freedom are equal. Some are more important. Now, if I told you, you had to wear a motorcycle helmet or a bicycle helmet as you leave class today, some of you would be fine with that. Some of you might not. So there are lots of different factors to consider, depending on what the problem is, depending on the cultural environment in which you're sitting. And these are things that you can ascertain data about from the population, and either through surveys or by talking to your community leaders and stakeholders. Equity is another issue that is very important to consider in our public health intervention development. And there are two types of equity that I like to talk about. Horizontal equity, you may know as universality, and vertical equity. Horizontal equity refers to the equal treatment of everyone. So everyone gets the same protection, as distinct from vertical equity, where we might treat people differently in order to make them more equal. For example, we might give car seats out only to people who can't afford to buy them themselves, so as to make their ability to achieve safety for their child passengers more equivalent. We might make special provisions for children where they're not able to make their own decisions, or for people with disabilities who may need extra help and can't operate fully independently. A lot of things we would argue we want horizontal equity where everyone is protected the same, where we have fire safety protections in every building, or we have safe roads that everyone drives on. That's easier for some things and appropriate for some things, whereas other things, to achieve vertical equity is important, and is an important element of achieving some of our public health goals of non-discrimination. So things to think about. And sometimes you'll use one, sometimes you'll use the other. And you may try to implement elements of each. Stigmatization is another value that often gets considered. What kind of stigmatization? Is it likely? Who gets stigmatized? How desirable or undesirable it is. For example, I mean, to go outside of the injury area for a moment, I think we would all think it was pretty stigmatizing if an adolescent in school, in order to access reproductive health services, had to raise their hand and say, yes, I'm sexually active. Or for a child in a classroom to be said, well, to be asked, are you in the free lunch program or not, could be stigmatizing. And so I think, for most things, we try to avoid that. There is one area I could think of where stigmatization has been used as a tool for intervention. I mean, you may or not agree with it, but for example, making lists of offenders available so that sexual offenders available so that people can see in their neighborhood if there's a sex offender next door or down the street. And that's a form of stigmatization that's been put in place for the purposes of safety. And maybe something, there may be other examples to think about. And you need to decide, the particular type of stigmatization and how desirable or undesirable it might be. And often stigmatization happens inadvertently, without people realizing that it's happening. And so it's something to keep an eye out for, even if it's not something that you think is actively part of your intervention. There's also issues around the preferences of people or and the community that you're working with. Do people want this intervention, and will they accept this intervention? And it gets at whether or not this issue is a priority for people. And I remember some students one time telling me they'd gone out into community to work, and they were convinced that what was needed was interventions around cardiac safety and cardiovascular injury prevention, or cardiovascular prevention, sorry. But what people really wanted was safe playgrounds. And so they had to learn that, okay, well, let's first talk about the playgrounds, and then we'll come back to the cardiovascular issue later. And finally is the issue of feasibility. And as I mentioned, I always put this last because I think if you think about it too early on, you might dismiss interventions that are potentially useful, but that you get rid of them too soon in the process. And if you think about it a little more, might actually be feasible. So I think about two different types of feasibility. Technologic feasibility. Does the technology exist to do this intervention? If the answer to that is no, you probably need to ditch it pretty early in the process, right there and then. If you can't do it, you can't do it. But realize that you might be able to do it at some later point. I mean, 20 years ago, we didn't have cell phones. We didn't have, well, maybe it was more than 20 years. But anyway, we didn't have the technology in cars to identify where a crash happened and to send help. And then there's also the issue of political feasibility, and whether or not there's political will to make this happen. And that one often, if we think about it too quickly, may keep you from trying an intervention. Whereas if you think about it long and hard at the end, after you've come up with some ideas that you really like, often where there is some energy around advocacy, political will can be changed. So then the next issue is how to use the third dimension to compare your options. With your group of stakeholders, I think you need to be sure to define what aspect of each value you mean. I already talked about that as we went through the values. Assign weights that represent how important each value is, however you have defined it. How important is it in this setting at this time? What is important, as I said, in one community may not be the same as what's important in a different community or in a different culture, or that may be different. I mean, we have different values about searching as we get on airplanes than we did before 9/11. So it's time and location dependent. And I would suggest that you use a scale from 1 to 10, 1 being low importance to 10, high importance, and assign each level of importance to the values that you've expressed and defined. And so here I've just put in some examples for the purposes of illustration. And then the next step is to consider how each prevention idea rates on satisfying each criterion as you've defined it. And I usually use on a scale of very poorly to very well. So -3 to +3. So let's look at an example. So you have prevention idea 1 in the first column and prevention idea 2 in the second column. And so on effectiveness, which you've rated as a 6 as being very important, you might decide prevention idea 3 is really good with respect to effectiveness in the way that you're looking at it. Whereas prevention idea 1 is good, but not as good. Whereas the cost for prevention idea 1 may be somewhat prohibitive, and so you give it a -2, whereas the cost for prevention idea 2 is not quite as bad, and so on. So again, I've just made up the ratings here, but to illustrate the process. So you go through this for each of your prevention ideas. I've shown 2 prevention ideas here. You can do any number that you want. And then what you do is you multiply the rating for each criterion by the score of poor to good of the intervention relative to the weight you assign to that criterion. And then you add up the total for each intervention and see which has the higher score. So here I've taken what I showed you and multiplied, the effectiveness of +3 multiplied by the value of 6 gives you a score of 18. -2 by the value of 2 gives you a score of -4, and so on. And then you add up across here, and this one gets a 45, and this idea a 6. So looking at it, this one is much more highly favored and meets your criteria better than the other intervention. You can consider scores for as many intervention ideas as you feel is appropriate, but it's probably easiest not to do more than 2 or 3 at a time. And from there, you decide among the options you have compared. And then you can notate and explain based on the criteria and decisions you've arrived at, so that when you're talking to others to advocate for this intervention, whether it's advocating with county commissioners, with a tribal council, with your local community, you can explain more clearly how you arrived at the decision that you arrived at for which intervention to employ. So in closing, I mean, I think the advantages of using the third dimension and doing it as a group forces clarity about what's important in the decision process in this community, in this point in time, community or setting. I mean, it might be a whole state. It encourages the use of data to inform decisions, and it facilitates participation in decision-making by a structured process so that the necessary people and a group of people can participate, but they have some structure around it, and it's a more organized process. And then as a result, it makes it easier to talk about the reasons for the choices that you made, potentially resulting in more effective advocacy. So continuing through the planning cycle, as you see here, going back, we've just been down here in this element down here, as I said, and there are many other parts of the process that you'll learn in other places. But I want you to remember that the matrix and third dimension I presented here in the context of injury, but they can be used in addressing any public health issue. And I urge you to try it. And I've had students who have learned this in my injury course, but then gone on to do other things, write to me and say, I used it for schistosomiasis in West Africa and it worked. Or I've used it for cancer control in my county health department. So I know that it can be used. I know that it works. And I encourage you to try it on whatever problems you're working with. But to get some practice, here's an assessment activity that your instructors may want you to do, where I would urge you to fill out a Haddon matrix related to a topic. And I gave some examples here of topics you might want to consider. Be sure to define each column and row before you start. And then select 2 prevention ideas from your matrix and pick 3 value criteria to consider. Follow the process that I've described for doing the third dimension, and then write a brief paragraph or a few bullet points to justify your decision between the options that you considered. So it's just a way to practice the process. And I think you'll find it very useful. Here's some references that can help you if you want to read a little bit more or forget something that I may have explained here. Haddon's paper with his original depiction of the matrix, and then my edition of the third dimension, and then a third paper that kind of combines the two. So thank you for your participation, and I hope this was helpful.